funny, really, because doctors, we think of ourselves as scientists. It's ridiculous to say that for so many of us. I wasn't asking why at all. Science is about interesting questions. I wasn't asking any interesting questions. I was just doing blood tests and then prescribing. And I think the power, we need to start being curious. Instead of those N=1, they shouldn't be ridiculed. They show it's possible. And if it's possible once, it may be possible a few times. And then the question is, well, how does that fit with your hypothesis?
Good morning, everybody. Hey, David, how are you? Good to see you. Can you hear me okay?
I can hear you all right, yes.
I should say good afternoon. I'm sorry, you're in the UK, so it's 5 p.m. there or something like that, if I'm not mistaken.
It is 5 o'clock. So there's quite a crowd of us here.
Yeah, there should be some more folks jumping in a little bit. They're all muted, so maybe they'll type some questions into the chat if they have an interest, but otherwise it's you and I having a conversation. I have to say, it was lovely meeting some of your co-conspirators while I was in the UK. I had dinner with Asim and Graham Phillips and Sam Felton and Olivia, and all part of the Public Health Collaborative, which I know you're part of. And then of course we spoke with your wife Jen earlier this summer. So it's good to see you. How are you doing these days?
I'm a very cheerful GP, really. I'm surprised to be as cheerful as I am, because what with COVID and everything, I should be miserable. But really, I'm not. I'm loving my job. Every clinic's full of amazing cases. And so I'm very cheerful, actually. And we live on a farm as well, so that's a nice place to live.
Yeah, I remember last time you talked about you had pigs and chickens and all kinds of animals running around, so good for you.
Well, we've eaten the pig now.
Oh, okay. So pig's gone.
So I'm afraid the pig, there's what's left of it in the freezer. But yes, the chickens are there, and sheep and geese at the moment.
Very nice. Very nice. And so I want to just go back to this point. You said you're a very happy GP. And I think a lot of physicians are kind of not. I mean, it's even though a lot of people say, well, physicians are so privileged, they've got this education, most of them make a decent living. And many of them are, just not happy where they're at. And I think part of it has to do with the fact that they just continue to, I think, fail at what they intended to do when they set out, and that is to improve the health of people, because I don't think we're really doing that in a large degree unless, you do something like you're doing, which is very lifestyle based. So how long, Dave, remind me, how long has it been that you've sort of taken this tact where, you went from, maybe a standard GP doing the thing that everybody else does to where you're focusing on lifestyle now?
Yeah, the big change was 2012. Up until that, I think I'd probably be in my mid-50s then. And I think, Shawn, most of us, we become a doctor to make a difference. And I was really disappointed in myself and in medicine, because really I didn't feel I was making a difference. So I was all ready to pack my bags. I knew I'd looked at my retirement package, and like many, many of my colleagues, I was going to go early. And here I am, 10 years later, I'm still here. And I think I'm now the oldest working GP, certainly in about a 50-mile radius. And that's very, very sad, really. And all my colleagues long since went. And now even some of the doctors I trained are retiring early. So we have in the UK something of a crisis, really. So many healthcare professionals are not enjoying it. Just like I was disappointed. And I think we're memorizing protocols, aren't we? And instead of really anything exciting science-wise, thinking about the actual reason our patients are ill, I find many young doctors are just memorizing all the various protocols, doing tests, and then it boils down to prescribing. But you don't often, if you do that, you don't often see people that look really well. And I think that was one of the things that had dogged me for years, where I thought, well, this is weird, because I so rarely see people in middle age actually looking properly well. And that's the big difference now, because in every clinic I do, I'm seeing old people, middle-aged people and young people shining with health. And in fact, one of the first things I notice is their eyes. And within a few weeks of eating better, people's eyes are so much brighter. And then their skin is the next thing. I mean, all things, Shawn, I'm sure you're seeing very often too.
Yeah, and there's a lot to be said. I know a lot of people say you can't judge a book by its cover, but that's one of the first things you learn in physical examination. You take a general assessment with this patient, what it looks like when they walk into the door. Do they look older than they're supposed to be? Do they look generally unwell? And you can see a lot through the skin and the eyes, and it's kind of a window to what's going on. But I wanted to, you mentioned that because you're not that old, David. I mean, you said you're mid 60s, so you're not.
I'm 60. I'll be 64 in 2 weeks.
Yeah, time. That's in my book. I'm 55, so I'm like, I don't think that sounds old to me at all. I plan to be going strong in the mid 60s and hopefully into the 70s and 80s. So, I mean, there's no reason. And it's shocking to me to hear that all the physicians in the UK are retiring in their 50s and stuff. My gosh, that sounds just really, really crazy to me. But, well, let's talk about why you're having so much fun and why you're smiling and happy to go to work, whereas other guys, they begrudgingly drag themselves in. I got to where, as a surgeon, it was just, another day, another knee scope, or another 5 knee scopes, or another 3 joint replacements. And, it was kind of fun the first time, but then it just becomes routine and almost like you're just a cog in the wheel, and all you're doing is spinning that wheel faster and faster for the hospital administrators to make the profits is how the U.S. market is going. And so you just kind of feel like, am I really, am I progressing here? So how does, like I said, what does a typical day look like for you, and why are you happy about it?
Well, it starts with the blood results. I used to, I'm sure most doctors spend a lot of their time wading through the blood results of all the patients. And that used to be something that was a tedious procedure as I went through all the misery and tried to file them and code them. But that has completely changed because it's a treat now looking at the blood work, an absolute treat. And that's because again and again and again, clinic after clinic, I cheer myself up when I get there by looking at the blood work to see what's happened to people I know, what's happened to their lipid profiles, particularly the triglycerides improving, what's happened to liver function test, and what's happening to the hemoglobin A1C, the marker for diabetic control. And that has changed because mainly people were getting worse and worse. And then I was sort of nagging them before. Now it's so different. So the clinic starts with a bang because I'm looking at these blood tests, and many of them are astonishing, improving so much. And then, of course, some of them become, as you may know, Shawn, on Twitter, graph of the week.
Yeah.
So that instead of most GPs, we sort of tell our patients off and moan at them. I'm ringing them up to say, wow, your diabetes is the best it's been for years. And then we actually call it the happy post. There's so many graphs that get posted out every week that my staff, it's nice for them to do something cheerful. So we get the graphs of progress and we post them out every Monday and Thursday. And the patients, these graphs are stuck up on fridges all over the northwest of England where I practice. So the day starts completely differently. The blood work is different, and there's often an opportunity to ring people up. And why not? Why should we not just spend 2 minutes ringing somebody up and saying, you've done amazingly. Wow. And they love that. It's a great surprise when your doctor rings you up to give you good news. And it's nice. It's great for the doctor too. It's just win-win. So I enjoy that a great deal.
So, and what is facilitating this winning? What are you doing nutrition-wise? I mean, I kind of already know, but I mean, I'll let you describe that.
Well, I think for me, the whole thing centers around sugar, really. But the thing I had missed is that starchy carbohydrates digest down into surprising amounts of sugar. And how I missed that till I was 55, I do not know. But what an error. What an error. And so I am helping my patients cut the carbs. And we're constantly searching for the sugar. Is, somebody's blood sugar is high. I'm always interested. Why do you think that is? So I'm searching for the sugar. Of course, the thing to debate, Shawn, is if you cut the carbs, what do you replace them with? Mm-hmm. And there's quite an interesting worldwide debate at the moment about, well, are you going to increase the protein, which presumably, Shawn, looking at you, that's what you've done. Mm-hmm. You could increase the protein, or you could increase the fats.
Well, some people would say you could. Some would say you can increase the non-starchy vegetables and increase the fiber is what There's some people that would advocate for that as well, I suppose.
Yes, you could do that. You'd have your bowels would be amazing if you did that. But and yes, so I would say my patients basically what they're doing is they're basing their meals on protein. So I'm saying, start with whatever protein you enjoy. Mm-hmm. Is it fish? Is it meat? If it's meat, what sort of meat would you enjoy? And or eggs or cheese, whatever. And then add in some green veg and a bit of sauce to make it tasty. And that's my I only have 10-minute appointments, you see, Shawn. So in the health service, we have to get a cracking move on. And so that's my shorthand way with a patient. We're looking for the sugar. We're going to cut that stuff out. You're going to base your meals on protein, add some green veg and some sauce to make it, or butter or whatever to make it tasty.
Let me just go back a little bit. You said you have 10 minutes. Why? Why do you only have 10 minutes? And what happens if you say, this patient needs 30 minutes? I need more time with my patients. What would the NHS do to you? Do they say?
Well, just hollow laughter. Listen, Shawn, when I was trained as a GP, I was given 5-minute appointments, 5 minutes for each patient. Yeah. And then luxury of luxuries about, 15 years ago, we went up to 7.5 minutes for each patient. And now I'm given 10 minutes because there are so many, there's so many patients you have to see that I can't be given longer than that. Now, what I actually do is I start the clinic early, an hour early, and I fit some in early to give me a bit longer. And then my patients now, I've looked after the same population since 1986. I know my patients very, very well. And they're very indulgent of me, really. So if they have to wait longer, I do apologize, but they don't mind. They don't mind. But anyway, officially it's 10 minutes. And that everybody, we're nine doctors in our practice. Nobody gets more than 10-minute appointments.
Yeah, reminds me, when I was deployed over in Afghanistan, we had some Egyptian doctors. We had all these NATO different forces, and the Egyptian doctors were seeing 500 patients a day. I mean, one physician, 500 a day. I'm like, they literally like shine a flashlight at them and move them. Yeah. It was like, what can you do in that? You literally have 30 seconds per patient, but that's what they had basically. So it's almost comical when you think about it. But so, you've got, I guess, 5 minutes. It takes you at least a minute to describe the diet and then some of the paperwork or something like that, 10 minutes. What, as far as I know, you've put out many, I've seen some of your data. You've shown, hey, we're saving the NHS, tens of thousands of pounds every year. Has that made an impact on anybody at the higher levels? Are they saying, hey, look, this, we got a limited money supply. Why don't we look at this?
Yes. Well, that's a good question. There has been some impact. I won NHS Innovator of the Year a few years back out of the whole of the NHS. So even compared to orthopedic surgeons, Shawn, and everybody else in the health service, I was the winner of Innovator of the Year. And that was because of what I do is very unusual and because we spend a lot less on the drug budget. The tragedy is in the UK, the savings on the drug budget are not kept by the practice. They're kept by the treasury. So I dare say the Treasury are very grateful to me. And I have actually been to the Treasury in London, and they hosted a thing that I gave some speeches, and they're very grateful for this money. But I wish I could have it to recycle into patient services. So yes, the media are very interested here. So I've probably written 30 or 40 articles now for the Daily Mail, our most popular paper. I've done a BBC One documentary, The Truth About Carbs, and that went to 4 million people. There's a great deal of interest, but less interest perhaps from official sources. This is essentially, Shawn, I think it's a grassroots revolution, this.
Yeah, I certainly see that. Yeah, I don't.
It's driven by social media. Intelligent people are beginning to ask questions, and many of them wonder about the medication they're taking, or whether, what could the doctor do this differently? And then they search and find examples on Twitter, particularly, of people who seem to do well.
Yeah, I've posted my share of victories, over the years, and it's always interesting. Even it doesn't matter how many you put up there, thousands of them at this point, and people will still say no, it doesn't work. They'll deny it. They'll deny that. They would deny that the sky is blue because they said, well, there's a study that says the sky is pink, and therefore it must be pink, even though we can see with our own two eyes what's going on. Do you, as far as, obviously the criticism is always, particularly you tell people, oh my gosh, go eat some eggs or whatever, or some chicken or some, God forbid you say lamb or beef.
Red meat.
They're going to worry about, oh my God, there's saturated fat in there, and that's going to elevate my LDL cholesterol, and therefore I'm going to instantly die from that. How do you broach that topic? Because cardiovascular disease is clearly a very common thing. A lot of people die from that. I mean, it's still the number one killer in the developed world.
That's interesting, Shawn. That brings me to a story, really. So in the early days, in 2013, I was a very lonely low-carb GP, because in the UK, I think I was probably the only one. And if I went to clinical meetings, I was heckled and shouted at. Because people thought that what I did was dangerous. But those people did me a great favor, Shawn, because I started collecting careful data. So we had the continuity of care in the UK means that I look after people for decades. So I've got data, and we're well computerized as well. We have a lot of computer data. So I had the baseline for my patients, and then because I was frightened and lonely, I started collecting data. And the data that I found, first of all, the lipid profiles improved significantly for my patients. All of the lipid profiles just improved. And then renal function as well. I was told, all this protein, the renal function will deteriorate. But I can tell you, Shawn, it doesn't. Then the next thing was I could see that I was not going to be taken seriously unless I started publishing my work in proper, respectable papers. And so that I think I've now probably published about 14 or 15 papers. I've got another one coming. So it's interesting how your enemies do you such a service if you listen to them. Because I had people shouting. So I thought, well, how do I was wrong before, I could be wrong again. I collected data very carefully. I've got a wonderful database now going back 10 years, because from the very first, the first patients, there was 18 of them. I collected their data, and then I've got data on hundreds of patients now. And so I would say to people, well, on average, I know I can predict what will happen to people who live in Southport in the UK who come to me. 50% of all the people who go low carb will achieve drug-free type 2 diabetes remission. That's my remission rate is actually 52%. And they will achieve improved lipid profiles and probably improved renal function. And on average, they'll lose 10 kilograms. So that is very reassuring. And I would just say to physicians, collect data, and then you can audit your data, and then you can tell patients what will happen.
Yeah, I want to, because I know I saw the study you published, I don't know how long, maybe it might have been a year ago, on the renal function in diabetics. And so let's dig into that, because you're basically telling them to increase their protein and reduce sugar and starchy carbohydrates. And we often hear, hey, protein is going to be damaging to the kidneys, particularly if you already have chronic renal insufficiency, which I think some of your patients had. And you actually saw the opposite. Is that correct?
I did. And I was fascinated really by this. So that paper was written with the help of a professor of nephrology from Liverpool University, and also a very senior dietitian. And we did two things. The first one was we drilled back into the papers that had suggested renal function would deteriorate with dietary protein. And I was in for a surprise, Shawn, a big surprise. So I think the paper is by Brenner from about 1986 or 88. Mm-hmm. This was behind a paywall, and I think it cost me $30, but it was $30 very well spent. This paper has been cited hundreds of times. And as I read the paper, there was data on harbor seals, rats, guinea pigs, even vampire bats. But what they didn't have was data on humans. And they extrapolated from feeding harbor seals, rats, guinea pigs, and so on and so forth, protein. And really, humans are not the same as vampire bats or guinea pigs. So I was really astonished. And so the professor of nephrology and the dietitian, we couldn't really see quite where there is reliable evidence, certainly for people with either normal renal function or moderately reduced renal function. So that was part of the paper. And anybody interested, all you've got to do is Google Unwin and renal function, and you can read my paper and all the references there. So that was part of it, was a review of the evidence. And then the next one, well, what does damage renal function? And in my opinion, it's sugar. It's sugar that damages renal function in many different ways, all of which I detail in the paper. And then there was our own, on top of that was then the audit of what happens if people go low carb for a period of years to their renal function. And of course, bear in mind, Shawn, people with diabetes, the average age was, I think, 62, and they had diabetes. So the renal function should have deteriorated, because at the end of the audit period, on average, they were 2 to 3 years older. But the renal function did exactly the opposite of what we expected. Instead of deteriorating with age and diabetes, it actually improved. So the p-values on what actually occurred were minute. So it was thought to be very significant. And that is given me confidence, really, to this protein renal business.
Yeah, Stu Phillips' paper in 2018 also cited this Brenner hypothesis as being, there's no human data on that. It's a mouse, basically mouse model vampire. I didn't know vampire bats and that type of stuff. And you said you think sugar is causative in renal disease, or at least in some of that. Why do you think that is? What is the evidence that would point to that? Is there associational data? Is there mechanistic data that would support that?
Right. So sugar does damage in all sorts of ways. One way that I think is of great interest is, I'm sure, Shawn, you've heard of the glycocalyx. Mm-hmm. This is the non-stick lining of our arteries. And we know that even in healthy people, if you induce high blood sugar, it reduces the thickness of this non-stick layer by 50% within 6 hours of having a raised blood sugar. So that's one way in which a raised blood sugar, it actually damages arteries. The other thing is, Shawn, are you aware of the link between insulin and sodium?
Yeah, vaguely, yeah. I mean, I know they're like I know that. Well, I know certainly there's a relationship between insulin and potassium, and there's inverse relationship between sodium and potassium. But
okay, well, let me, because this is actually another paper I wrote, because I've been constantly fascinated and interested by what's happened to my patients, because none of the things I've observed were not what I was told I would observe. So never mind the renal function. The other thing was people thought, well, all this fat in the diet, will the blood pressure go up? And yet, in the very first patients and myself, I discovered my blood pressure dropped dramatically. I used to have moderately raised blood pressure, sort of 163 over 92. And of course, I never went to a doctor because I was damned if I'd be a patient for anybody. So I just ignored it. Then I went low carb and I discovered I felt dizzy when I stood up. Well, I took my blood pressure, it was 124 over 75. I hadn't had that since I'd been in my 20s. Weird, but it was happening to all the patients as well. And some of them that were on medication actually fell over because of postural hypertension. And I was forced to start deprescribing the medication for blood pressure. So for years, I was thinking, well, this is really odd and fascinating. The other thing I noticed was that my patients, I'm a bit of a runner, and I found that if I didn't have more salt in my diet, then I got muscle cramps. So this is odd. I had more salt, and yet my blood pressure went down. And then I had a really interesting case, Shawn. An old guy was supposedly terminally ill with heart failure. I'd known him. I was very, very fond of him. I'd known him for a long, long time. And his wife said, I know my husband is dying, but, he's a man with dignity and he's wetting the bed. Is there anything you could do with all these water tablets you're giving him? I know he's filling up with fluid because of the idea of dignity. And, I tried low carb. Now, 6 weeks later, he was mowing the lawn. And this guy was 83. And Shawn, when heart failure, when you get to that terminal end and you're hitting them with every drug you've got, they're very sick people. So how fascinating. So the guy had a diuresis. He started weeing loads when he went low carb. And lots of my other patients were able to stop their water tablets for swollen ankles. So we now have a fascinating situation of improving blood pressure despite increasing salt intake and people weeing more. It took me 5 years to get to the bottom of this. 5 years looking into the physiology. And I've written a paper on this as well. This one was written with Professor Brady, a professor of cardiology at Glasgow University. So you can all look this paper up. Anyway, we have known since 1933 that insulin causes renal sodium retention. So a high carb diet is a high insulin diet, and you're hoarding salt. You see, God didn't design us to live in this high carb environment. So that it wasn't, as it were, foretold that we'd have all these carbs, but we had lived in very salty environments, eating fish and so on. So there is a homeostatic mechanism for regulating too much salt. But if you have high carb, high insulin, you start hoarding the salt, your blood pressure goes up. And that relates to your original question, Shawn, that's another way that sugar can damage your renal function, because we know that blood pressure is very important in looking after people with renal problems. So you see, there's another mechanism. And I really think we do not talk enough about the link between dietary carbs and blood pressure. Yeah. We even in the UK call it essential hypertension, which drives me mad. And we call it essential hypertension because apparently we don't know the cause of high blood pressure. Well, I would dispute that.
Yeah, there's a whole slew of idiopathic diseases which we don't know, and I did know the relationship between insulin on the renal function. But let me ask you, because there's a recent paper that came out, saying what are the things you could do to impact your quality, your longevity, and one was eat more fruits and vegetables and decrease salt consumption. I think that was the overall impression. But my thought is, instead of talking about salt consumption, maybe you talk about salty food consumption. And if you think about where does most of the salt that we ingest come from, it's chips, it's processed foods, where salt is ubiquitous. And it may just be a marker for refined carbohydrate consumption. I'd like to see that stratified out as, how much of the salt are you getting comes coupled with all these refined carbohydrates. Do you think there's anything why that association might be? Is that part of it, you think?
Oh, Shawn, I absolutely agree. And of course, this is the problem with epidemiology, which so many of the studies on nutrition are epidemiology, which can only suggest associations. And I would agree that I personally believe the junk food that I think the other thing is, Shawn, when I'm changing the subject slightly, but when I was young, there weren't fat people, Mm-hmm. In my entire school, there was one fat child.
Yeah.
I remember this is a new phenomenon. In my lifetime as a doctor, people's health is deteriorating. Something has changed. I really believe a look around any supermarket is pretty convincing as to people are eating junk. In fact, I was in Minnesota last week, so I took the opportunity to pop into a couple of American supermarkets. Oh my God.
Yeah.
Dear God.
I have to. Yeah. I mean, I just laugh because I was in the UK and I was chatting with, I can't remember. Brian Rose from London Real about the fact that I don't see as many obese people in the UK, and the ones I did see were often American tourists. And so I can imagine the shock you have coming from the UK to here. And the UK is probably 20 years behind, I think. Give the UK another 20 years, right? It's coming.
It's coming. And what you would have seen, Shawn, if you'd come to the north of England where people are poorer, mm-hmm. the obesity here is poorer people are much fatter. And I noticed the same in America.
Yeah.
If you'd gone to the northern towns, it's terrible. In our own practice, I'm in the north of England. We've got 10-fold more people with type 2 diabetes now than when I was a young man in 1986 when I joined. 10-fold. I'm sure America's the same. It made me so sad, Shawn, really sad when I looked around and I could see young people struggling to walk because they're so heavy. What a tragedy.
It is. I, like you, I remember growing up in the 1970s, I was born in 67. And so I remember we had the fat kid in the neighborhood. I mean, he was the kid,
Yes.
there was only one. All the rest of us were kind of normal size and shape. And now, as you know, at least in the United States, we're not far off from 50% obesity rate. I think we're at 42 most recent, probably 45 after the pandemic. And so it is tragic. And the number, I literally did an interview yesterday with a fellow who was 520 pounds. He went on a low-carb carnivore diet for 2.5 years and got down to 210 pounds, got off all his medication, reversed his autoimmune diseases, on and on and on. Let me ask you, because there's so much emphasis with low-carb and diabetes, as there should be. I mean, there's a clear relationship with there. But are you seeing, and I know we've talked about this before, but I always like to bring this up, wins in other areas, arthritis, mental health issues, other things that are being addressed by diet?
I'm beginning to wonder what isn't improved. So skin condition, eczema, mm-hmm. psoriasis, definitely both of those, high blood pressure. Mental health is really interesting. Mm-hmm. So I'm getting some people come off antidepressants. And there's some really interesting international work on things like bipolar disorder. And just general happiness. People are more cheerful. I've noticed myself in the early days, once or twice I cheated, as you do. I remember one time I went to a 3-starred Michelin restaurant and the chef made me a very special lemon dessert and I scoffed it down. how I made that lemon dessert. It was like fireworks going off in my head. But, you know, I had significant depression for 2 days after that. Really weird feeling of doom and anxiety all mixed up. And so there's something about mental health. I'm sure of it. And it's being researched. There are RCTs coming through now. There's some work in Edinburgh just starting on mental health. What else? Joint pain. Yes, I really agree. People with knee pain and ankle pain and so on. I've had 1 or 2 are listed for surgical operations that they never need. Sleep apnea, that's another one. COVID was interesting because all the clinics kind of furred up. And I started, instead of referring cases of sleep apnea to the clinic, I started treating them, and I haven't failed with a single case of sleep apnea. There's only 5 or 6, but each one of those would have gone on to need a mask at night or whatever. What else? I'm still thinking. Oh, irritable bowel syndrome. All of those people with bloating, abdominal pain. I blame wheat for a lot of those. A lot of them improve. I think polycystic ovarian disease is another one I've seen improvements in. So you can see, Shawn, the thing is, I worry that it looks like I'm overclaiming, looks like I'm a quack. And in fact, well, of course, there are people who say I am. But it's what I'm observing. And these are all NHS patients. I don't make any money out of this. I tend to lose money. But it's intriguing and fascinating. So many of the diseases I previously was prescribing for, I'm not.
Yeah, that is, and that's the thing that I think, you know, within the low carb, because you know, when you get into these debates about weight loss, you know, there's a lot of ways to lose weight, and I think that's fine if you want to go on a low fat diet or calorie restricted diet and you lose weight, and that's your prerogative. But what I'm seeing uniquely is these big other things, mental health. I'm sure you're familiar with work with guys like Chris Palmer and some of the other folks, and I know Georgie and Eric Westman published that study on bipolar and schizoaffective disorder and depression, and saw those people with, you know, going on a ketogenic diet saw significant improvements. And so we're seeing these papers all the time. And I think, you know, it would do us good to, you know, really emphasize that instead of fighting the weight loss trenches. You know, when I wrote my book, I said, I don't like talking about weight loss because it's such a contentious topic, and I don't really care how you lose weight. You know, I'm more cared about how you get healthier, quite honestly. Do you, so you said you're thought of as a quack in the UK, and I was like, well, maybe better than a quack than a physician pharmaceutical Pez dispenser, you know, where you just kind of, you know, I mean, you got some that are another extreme, and it's just like, you know, it's like, you know, here.
Well, most people are very kind, really. Yeah. The early days, it was difficult, but I think we're getting traction in the UK. There are thousands of doctors now promoting low carb, and hundreds will, if I give a talk, hundreds will come. Many of them are young doctors. That gives me a lot of hope. Many, many young doctors are disappointed, really. They know it doesn't feel right. So there's a big movement to do things better and look at the actual causes of illness rather than just prescribing straight away.
Yeah, that's, you know, one of the things is, you know, like I would just use this simple sort of scenario. Like if you come into the doctor's office, and you have an achy knee and it's inflamed and my knee has inflammation, they said, well, here, take this anti-inflammatory. Here, take your Celebrex, your ibuprofen. Here's an anti-inflammatory. And then the question should be, well, why is my knee inflamed in the first place? You know? And if they can't answer that, then there's a problem there. You should know why this is occurring. Because if you don't know why it's occurring, then you don't know, you know, you're missing out on a lot of ways to treat those types of things. And so I say, and I think a lot of the curiosity of it, we don't ask why anymore as physicians. We just say, it is what it is, and this is how we treat it. And instead of saying, why is this occurring? Which is, I think, so important.
Shawn, I so agree with you that it's funny, really, because doctors, we think of ourselves as scientists. It's ridiculous to say that for so many of us. I wasn't asking why at all. Science is about interesting questions. I wasn't asking any interesting questions. I was just doing blood tests and then prescribing. And I think the power, we need to start being curious. Instead of those N=1, they shouldn't be ridiculed. They show it's possible. And if it's possible once, it may be possible a few times. And then the question is, well, how does that fit with your hypothesis?
Yeah, I mean, I've got, in this meeting right now, there's a guy, Kevin, in here. He's reversing multiple sclerosis. I mean, he was basically, non-ambulatory. Now he's out juggling by dietary. And this is something, that many physicians would say, well, sometimes it happens, and that's the end of their curiosity to me, which is kind of abhorrent. I mean, you think, why aren't you crawling up this guy? You'd be crawling up this guy and examining everything he's doing. And he's not the only one. I know a number of people now with MS have seen improvements through dietary means, and you can go on, major depression and all these things. And yet when they go and they talk to their physician, they say, well, good job, keep doing what you're doing, but no curiosity, if they're willing to accept them eating a meat-based diet or a diet that's low carb, higher fat. Some of them will just outright say, you're crazy, you're going to kill yourself, stop immediately. A few of them will say, good job, keep doing what you're doing. But very few of them will say, this is really interesting. Can you talk to me more so I can apply this to my other patient, which I think is a shame.
It is a shame. I do understand, though, Shawn, and I remember in the early days, I hated Dr. Google. I hated patients who came in and had looked it all up on Google. And I used to say, well, I think I'm the doctor here, and all the rest. It was horrible of me, but it's wonderful if people are curious and if they're interested in their health. I now use that to everybody's advantage. So well done if you've looked something up and you're interested in your health. Yeah. That should be something that a physician would applaud. We're not priests, and this is what I mean, where only I can interpret the word of God as a doctor.
Absolutely.
That's what I used to be like, but I'm not now.
It's interesting. There was a meme going around, it says your, 20-minute Google search does not equal my, 15 years of training. But then the counter to that is now your 1 hour lecture does not equate my 20 years of living with this condition. And so, people have a lot of skin in the game. They have a lot of self-insight. I know if I had some disease, I would be constantly looking up. I'd become an expert in that disease. There's no doubt about it. And some of these people are.
I agree, Shawn. And my model now is each of us could see ourselves as a lifelong experiment. And I know you've done this, Shawn, noticing, well, I'm better if I do that, and I'm worse if I do that, because over time things change. And I think that attitude isn't far wrong, where you have an open mind. And I've experimented, as you have, Shawn. I've experimented with all sorts of different diets to see, well, which actually suits me. And you learn stuff. And Jen and I, we don't all have the same diet. Everybody's diet is a little bit different, and that's fine. It's absolutely fine.
Regardless of your dietary religion, and I think there are some dietary religions out there, whether it's carnivore, Mediterranean, vegan, vegetarian, I think the uniquely common thing is we see that, all of them are reducing these ultra-processed junk food. I mean, you can argue about how much processing is good and bad, but we all, it's kind of like when I used to debate about pornography. We know it when we see it. Well, I think you know it when you see it when we talk about junk food. I mean, I know that, somebody saying hamburger meat is processed, well, that's kind of nonsense. And somebody saying that, sliced vegetables are processed, it's kind of silly. But if we know pretty clearly, I think every dietary religion is going to exclude processed foods. Why aren't we why don't we have a campaign why isn't the NHS saying stop eating all this stuff in a real significant way? Why is that not occurring?
I wonder, Shawn. I think because there's so much that we could all agree on. Is anybody really saying ice cream is healthy? Is anybody saying donuts are healthy? Pizza is healthy? I would imagine most people would agree that avoiding junk foods is a good thing. And that's why I think sometimes it's a better idea, rather than fighting all the time, of which there's a lot goes on. There is would be better if we agreed, because actually almost anything's better than the average American diet. Mm-hmm. You know, whether you become a pescatarian or a carnivore or whatever, it's better than what I saw in the poor people eating in Minnesota, which wasn't, in my opinion, not proper food. So I think there's a lot of things we could agree on. And yet, I think people are defensive of their own thing. So there's a lot of kind of my diet is right, rather than, well, let's experiment and see. And then, of course, capitalism comes into it as well. And then there's big pharma and, you know, the confusion. This is what they've done with denying of global warming. And it's what they did with cigarettes, isn't it? Where there was confusion about what the experts say. So I think there are many, many different streams as to what's going on here, which particularly mystifies me in the field of diabetes, which is my passion, because surely we can all agree that things that put your blood sugar up are not a good idea. And yet I'm told it's meat makes diabetes worse. And in that, Shawn, I would disagree. I would agree with you. I don't see meat making diabetes worse. I really don't. Shawn, I don't know how long we've got together. I do hope I'm going to get time to talk about regenerative agriculture and my various bird reserves and how that relates, because I've never publicly discussed that ever. Well, people may have heard a lot of this already.
Let's go right now. I've got about 10 minutes left, Dave, so I'll let you chat about regenerative agriculture. It's a great topic. I'm very, very, very interested in that, and I talk about it often. But let's hear what you want to talk about on that.
Thank you. Well, so the first thing is, so I have been involved in the world of wild animals since I was a small child. And in particular, I've worked for the 3 Owls Bird Sanctuary in the UK since I was 13 years old. And so that's more than 50 years of work understanding wildlife and ecology. And in fact, I'm now the senior trustee of the 3 Owls Bird Sanctuary. And people leave us money and we buy land and then look at how can we increase the biodiversity in that land. How can we have more birds and mice and all the rest of it? And I want to tell you about a 2-acre field of leeks, because it gets to the heart of some of this vegetarian versus carnivore thing. There was a field of leeks. And it had grown leeks for many years. It was a monoculture of leeks. And in that field, nothing lived other than leeks, because they sprayed it twice a year with a herbicide, once a year with a pesticide. So that produced a lot of leeks and nothing else. And then that field has become one of the, I think it's 6 reserves I manage now. And after 7 years, there are now 20 species of bird and 135 species of moth and 3 species of bat, and so on and so forth, living on that 2 acres of land. And so one of the things I would say, if you're looking at land and you're worrying about animals, is we should be thinking about not just the 2 or 3 sheep you might kill and eat if they lived on the 2 acres of land, but what about, if you grow leeks, what about all the animals that never get to exist? So on that 2 acres of land now, there are barn owls hunting the mice at night and kestrels during the day, and then herons come in, eat it. How many mice are on there? There must be thousands. But nobody ever talks about, you see, they talk about the sheep you murder and eat. But what about if you have a monoculture? What about all the animals whose existence you deny the opportunity of them ever existing? Because the monocultures are, in my opinion, a worry. And so I think when we're looking at the food supply, we should be looking at what is the best use of each acre of land. A lot of England is not suited to crops at all because it's just too wet. Most of Wales and the Lake District really can produce lamb, but it can't produce wheat or oats or anything else. And then on top of that, we should be considering what's the load of pesticide, herbicide, fertilizer that each acre requires, and that should be costed in. Or in California, the water you're using needs costing in. And if you did that and you thought about each acre of land and you thought about carbon sequestration in the soil and you looked at what was happening with the soil and you factored in the herbicide, pesticide and the biodiversity, some aspects of regenerative agriculture start looking very, very interesting. And I want to give you an example of some regenerative agriculture I've done myself, because I do actually worry about the animals that I eat and the planet. And, people often think that maybe I don't care, but I actually I've cared since I've been a child. I wouldn't have run all these bird reserves if I didn't care about wildlife. But this, back to the experiment. So another one of my reserves, this was a larger reserve and we had about 3,000 trees in there and a few orchids were growing. And then as an experiment, I introduced sheep over the winter. And we found that since I've introduced the sheep, within 2 to 3 years, the number of orchids have quadrupled, or in fact, this year I couldn't count them. We started off and there was like 5 orchids, but this year it wasn't possible to count them. And it's because the sheep eat out all the undergrowth and disturb the ground, and then the orchids can grow. So here we're producing lamb, we're producing wildflowers, birds of prey, and I don't know what else, and all these orchids. And that got me really interested in regenerative agriculture. Is the way that we produce food, whatever we're eating, is it sustainable? And I think we all need to think far more about that. And I know there are people in America think a great deal about it. At heart is something about the soil and how you care for your soil. So I just wanted to share that with people, really, this idea that it is possible to eat meat and it be good for the planet, but it does depend on where you source it. And is it grass-fed? How was it produced? And this is why, Shawn, we produce so much of our own meat here on our farm to eat. That's why I have sheep, because I know where I can go and look at where my meat's coming from. It's grazing out there now, all the geese and so on. And each of us has a responsibility to show quite a lot of interest in this. At the moment, there's massive subsidies for the corn crop and the sugar crop. What if there were those same subsidies for the production of regenerative foods, regenerative agriculture? It's the end of my little lecture.
Yeah, I don't disagree at all, David. And like I said, in fact, I have a rancher coming to my house tomorrow. He's going to bring me some meat and we're going to have a podcast. But this is, a topic that, I've touched on many, many times. I've talked to a whole bunch of regenerative ranchers of different things. And I think clearly that is going to be part of the solution going forward. It has to be, and the fact that the really interesting thing is, you can increase the stocking rates. And so you can actually graze more animals than you could in a conventional system. And then if you can, over time, you can, the argument is, can you make it even more productive than what we currently have? And that's a contentious argument. I think, certainly you can approach that. And I think we can certainly, if our goal is to improve the environment, whether or not it's changing greenhouse gases to the degree that affects climate change or not, it does make sense to improve the biodiversity and enrich the soil and bring the animals and the bees and the birds. And right now with the massive pesticide and herbicide usage in the monocrops, you just decimate everything. You kill even all the insects. And, Stephen, who's in here, we talk about, when you kill all the insects, guess what else dies? Well, all the birds dies and all the lizards, all the things that depend on those insects start to die. And then all of a sudden you have this, this basically, bleak, sort of degraded land that is good for almost
well,
nothing.
yes, you have silent countryside.
Yeah.
And as somebody that runs bird sanctuaries, well, where have all the birds gone? Well, there's nothing for them to eat. That's why. So if there are no flowers, then there are no seeds. And if there are no flowers, there are hardly any insects. And then people go on about, these birds are endangered and those birds are endangered. Well, no wonder they're all starving to death. Yeah. One of the interesting facts, Shawn, is that grass that is grazed intermittently is more vigorous and produces more volume of grass. This is the basis for mob grazing. Mm-hmm. And I'm fascinated by these ranchers who can produce more meat per acre or hectare done in a regenerative way. They can double the stocking rates. Absolutely fascinating.
Yeah. And if they run multi-species behind it, they can even further improve the land capacity. So wonderful topic. David, unfortunately, I do have to go. It is a wonder. It's always a pleasure talking. Are you coming to the U.S. anytime this year to chat? Are you going to go to Denver or anything like that?
Oh, yes, I am.
Okay.
I'm coming to low-carb Boca.
Okay.
Yes, I've been to Denver a few times and it's a bit chilly. Mm-hmm. Now Florida, there's an idea. So I'm off. I want to see manatees and all your wildlife.
Yeah.
So Jen and I are coming to Florida mid-January to Boca. So that's our next thing.
Very nice.
Loads of things going on. And watch out for my paper with Roy Taylor. Professor Roy Taylor, that's the next paper, should be out in about a month.
What's the topic, if you don't mind sharing?
I don't at all. I'm, again, fascinated by what predicts remission of diabetes. So can you tell who will get remission and who won't? Okay. And also, what happens to the people who don't get remission? These are really interesting questions, which I'm answering in the paper using the database. And Professor Roy Taylor is one of the most famous experts in the field of diabetes in the world. So to get him as a joint author is amazing. And it represents something of a coup in terms of an end of the diet wars a little, that we should be curious about what works, whether it, he doesn't particularly agree with low carb, but he acknowledges that what we achieve in my practice is really amazing. And he's fascinated to know how I do it. So we've written a paper together, coming out soon.
Look forward to reading it. Anyway, David, thank you so much. Give my best to Jen and the sheep and the chickens and all that stuff. And keep up the good work. And I'm sure we'll talk in the near future again. Anyway.
Yes, Shawn, a great pleasure. Thank you so much for having me on. I'll come again.
Absolutely.
Bye-bye now.
All right. And the rest of you guys, we'll see you guys tomorrow. Everybody take care. Bye-bye now.